So only two persons are there. Okay, who is on duty, doctor? कोई भी नहीं है? हाँ? Okay. Well, उनको अजीब है। तब से go fast and come back. इससे आराम से जा रहा है। In the YouTube it is coming? It is coming? Have you checked? You first sit down. Take it. Next onward, you have to manage all those things. We are starting now. Okay. So we will be just revising the previous class also, and something new we are going to add on for this session. Can you check in the YouTube it is coming or not? Huh? So ECG ablation, it is basically the class we are going to take how we are going to do the procedure in the EP lab. So basics, which is not been taught anywhere in the books which we are touching here. And it is brought to you by our foundation that is called Heartbeat Foundation. It is the educational campaign from the foundation. And what are the things we are going to discuss in the coming half an hour to 45 minutes? The first is the basics of the EP study. Second is the normal conduction system, baseline measurement and approach to the EGM. So last time we have discussed regarding when we come to the cath lab or EP lab, what we want to look is the signals. And a lot of informations are there in the EGMs. You will be seeing green line, red line, white line, yellow line. And in those EGMs, how to identify that the signals is corroborating with a particular type of disease. So we call it a read between the line. And the most important information what we have to gather is the focusness. Where to focus in what particular type of disease, and accordingly we have to make our conclusions. So just you can say, seeing one eye, we have to anticipate what are the possibilities. One minute. You are seeing in this one?
लास्ट वीडियो
No, no, इसमें नहीं होगा, दूसरे वाले में होगा ना. You are seeing in the other one.
कौन सा screen?
दो रहता है, एक एजुकेशनल रहता है, एक दूसरा. It is going on here, na? It is showing already. See, one day time पर आके we have to start doing that also. You are wondering on here and the rate 30 times. Good morning. कुछ लिख रहा है. So focusedness is very important. So we have to see, we have to gather one information on which we have to make we have to start corroborating the findings and finally make a diagnosis. So just seeing the eye, we can anticipate what next is there. So in EP procedure, what we are going to do, we are going to do the three things. One is the pace, record, and ablate. So first we have to record the information, and most of the information what we do is that we are checking the signals. So we have to check the signals, and according to the signals, we have to make. Why it is not coming? It has gone. So important thing here is that we have to see the proximal part. So proximal part is the signals which we have to see, and distal part we are going to. So the proximal, this is the proximal, this is a distal, and the same nomenclature here. This is a distal, and this is a proximal part, and it is in the all the leads we have to see the same. So proximal usually is labeled as 9 and 10. Proximal means first, and distal means late. But when we are using the nomenclature in the EGMs, there is something different. That this conventional way of nomenclature in the EGMs, or we can say the EP lab, is the proximal is having the higher number 9 and 10, and distal, you can see the number should be starting from here to down. It should not be here to up. So this is the important convention that we have to apply wherever. So if it is there, it will be H his one. 1, 2, 3, 4. We are reading the EGMs which is coming on the monitor. We should be knowing that 4 means it will be somewhere here. So these signals we have to see, and then we have to see the one first signal. Both we have to correlate, and we have to make conclusions. So coming to the second point, the normal conduction system. So normal conduction system, we are aware that in the normal conduction system, the SA node is the main from where the whole signals are being what you can generated, and from there it will be going through the some atrial fibers, which has been middle, posterior, and anterior fibers, and through that it reaches to the AV node. This is also more what you call in the literature, but when the dissection has been done, it is not found in all the patients. So this nomenclature of internodal pathway is not well described. It has been challenged here and there. But after that, when it is reaching to the AV node, through the AV node, it will be reaching to the his bundle, then right and left. But there is one bundle which has been very well described, and which has been important side of pacing also. We call as this Bachman bundle. So Bachman bundle is the fastest fibers in the atrium, which transmit from the AV node through the upper part of the septum to the left atrium. So whatever activation is happening in the SA node, it will be directly transmitting without delay and reaching to the left side of the heart, left side. When it is this is called horizontal conduction system. So SA node, and it is going to the left atrium, and sometime we are pacing this Beckman bundle. If the patient is having a left atrial disease where the time is taking too much, so what we are finding, sorry. So what we are doing, that we are putting one pacemaker lead at the upper part of the septum, and trying to pace from that area also. Sorry. Coming to the normal conduction, this is the normal conduction. What we are seeing, that SA node, AV node, and then bundles, and it will be simultaneous activation. Most of the time, the right and left bundle is having the simultaneous activation. That's why the QRS is narrow, because the conduction is taking very short time to get transmitted. When there is a delay in either of these things, either the right is been delayed or left is delayed, you will be getting broad QRS, and it will be LBB or RBB. So this is a basic concept what we differentiate between the EGM and ECG. ECG means electrocardiogram, and EGM means electrogram. So what is the major difference? Last time we have discussed. Kote? EGM is an integrated electrical activity of the heart on the surface, and EGM is a localized electrical activity in the particular part of the heart. Localized. If you have put a catheter inside the left atrium, it is giving the information how the electricity is coming toward the catheter and away from the catheter. So that is called localized. So if you have to give an information, so in any what you call description, you can say Vivek is staying in India. This is called EGM information, ECG information. But when you have to say he is living in Hyderabad and presently he is in KR High Tech, it is called EGM. He is only giving that information, that location, particular location. So this is the description of the same information. You can say it is in Hyderabad or you can say in India. Both are giving electrical, but you have localized to a particular location. So what exactly is the electrical activity going in that particular geography? It can be vast, it can be narrowed down. So this is called narrowing of the information to the particular electrical activity. So coming to the, so you can see the, I'm not able to, it is lagging behind somewhat. So these are the information. You can see the surface ECG having two complexes, and these two complexes will be always common in most of the ECG. P and QRS means atrial and ventricle activation, and those electrical activity means the electrical axis as well as the amplitude will be defined by the particular disease. But when you are coming to the inside the what you call cell, here you can see that there are two informations as there. This is called CS means coronary sinus. These are his signals. His signals means we are keeping at the AV nearby to the AV node, and this is the surface ECG. So when we have to read the ECG, we start reading the ECM from the surface P. Surface P, whatever is coming down, this is the HRA means high right atrium. So high right atrium is the first signal we are expecting because the atrial activation will be happening at the SA node. So this is the first signal will be coming, followed by T wave, surface ECG. And you can see the same thing will be happening here also. But the atrial activation time, if you are seeing from this side to this side, the first HRA, then his, and then the CS. CS is the lower part of the left atrium. So it is happening late. So this is the activation pattern. Normally we get, after that there's a his, and then there's a ventricles, which is the integrated electrical activity of the whole heart, and the same thing has been reflecting here in the localized form. So this is the somewhat broader, and it is coming just in parallel to the ventricle. So we call as a V, and here the P is called A. So intracardiac P is A, and intracardiac QRS is V. So when we are saying AV means we are discussing about the intracardiac signals. When we are saying P and QRS means we are discussing about the surface ECGs. After that, you can see this is the ventricle, RV EGM, RV distal. So it is coming at the before the what you call his. So the RV apex has been activated first, and then the left. This is basically the left ventricle. So left ventricle is coming later part. So like that, the signals is being seen. You can see this is a distal and proximal activation, and we have to focus again how the electrical activity is happening. So these are surface easy, and then we have to start the RA, his, and other activity. And you can see this is the activation what I was saying. The first is the right atrial, high right atrial, and then it is the his, and then comes the CS. Same is for the QRS. So you have to just see. So this is the way we see the EGMs in the uh, EP lab. And this is the representative intracardiac EGM. You can see the same. First, we have to focus. We have to see the whole signals in this way. A V, and same thing is going. Now, why we do the EP study? This is the important question. Means all the patients are needing, or some patients are needing. So first of all, whenever we are having some electrical problems, we are suspecting either it may be SA nodal disease, AV nodal disease, pathways, or ventricular activity. Means we want to see how is the normal conduction system, means the AV node is functioning or SA node is functioning, and at the same time we want to know what exactly there is abnormal conduction is happening. The normal conduction is being late, or we have to modify by medicines, or do some sort of what you call treatment, either is a interventional or medical. And usually when we are doing the when we are suspecting any arrhythmia, when we are not having the arrhythmia ECG, normally, yeah, either you do by ECG, sometimes you will get by Holter or ELRs, you can get the arrhythmia easy. You can anticipate this patient is having particular type of rhythm problem. But there are conditions where the patient is having only 5 or 10 second, the time he is reaching is not getting that. So in those suspected cases, you are going to conduct a EP study. Whether that is because if a person is developing repeatedly palpitation and it is a paroxysm, means it is coming without any reason, and you are strongly suspecting, then certainly you have to induce and see what is the character. It can be VT, it can be AT, it can be supraventricular tachycardia. So how you are going to define and how you are, so for that we have to do the induction, means we have to induce the tachycardia, and it can be supraventricular protocol or it may be what you call so it may be a supraventricular tachycardia, means we want to induce the tachycardia, or ventricular tachycardia protocol. These are usual two protocols we commonly see, means whether we are dealing with the ventricular tachycardia. So how we are doing it? So any study is first preceded by, means if we are doing a AP study, we have to give like uh, how the conduction is behaving, means how the electrical system is. That is called the basic study. So we have to see the we are going to measure how much time it is taking from the SA node to AV node to his bundle to ventricle, and how's the pattern, it is a normal pattern or abnormal pattern. So those things will be defined by the baseline conduction study, means this is the first part of any EP study. This is the first part. We have to go and measure each and everything and say, okay, everything is fine, the conduction is taking the right time from SA node to AV node to his and his to, if anything is abnormal, we say, okay, this patient is having HV interval, means his to the ventricle is taking more time, so this patient is a clear candidate for the, we call as a pacemaker. Or then we are going to suspect there are either the patient may be having complete heart block as one of the possibility of his giddiness, or it may be a VT, because whenever the HV interval is prolonging, means there is some organic disease is underlying cause for HV interval. So the baseline sinus, we are going to measure A to A and B to V measurement. And then the cycle length versus rate. So whenever we are measuring in the cath lab, or we can say EP lab, we are not going to say the rate is 60 per minute, 80 per minute. We are going to use the word 1000, 600, 500, 400, 300. These are the words here. 600 cycle length. 600 cycle length का मतलब हुआ the patient is having the heart rate of around sorry, whatever the rate is there, 60,000, you have to divide it. So heart rate is 60, means we are saying 1000, 600, 500, 400, 300, means the heart rate is around 100 for 600, means if you are going to divide 60,000 by the heart rate, it will give the cycle length. So all the measurements are in the like a unit when we are using in the millimoles and milligrams. When we are in the EP lab, we don't use the word 60 beats per minute. This is not a common nomenclature. We are using cycle length, and usually all the measurements are in millisecond ms. So we are saying 600 millisecond, means, or 600, we are at the 600 the patient developed tachycardia. So we are saying at particular rate, means at that particular rate the patient is developing tachycardia. So this is the cycle length we are measuring. Now coming to the baseline. So what baseline measurements we are doing and how it is giving the information regarding the cardiac conduction system. So AHV, these are the three, and in that the most important information comes from the HBE, his bundle electrogram. There are three important. One is the atrium, his bundle, and ventricle. These are, that's why you may be seeing I am writing 3-wire EP study. 3-wire means we have kept one wire in the AV node, second wire in the RV, and third in the CS. These are three catheters we are normally using. Sometimes people use two also, and sometimes it may be four also. Four means the fourth will be in the high HRA, high right atrium near the SA node. So four catheters we have put, and we want to see the electrical system, how the conduction, where the first signal is coming, second signal is coming, third signal is coming, like that we are going to decide. But if you have to study by only single wire EP study, and you have to do all the conduction information, then what is the most important wire? Hmm? AV node, that is called his bundle electrogram. So that information will be coming the HBE, because it will be giving atrial, it will be giving AV node, means his bundle in and around, and after that it is giving the ventricle. So all information and 90% information we can detect from the only one gate, that is the HBE, means his bundle electrogram. So when we are doing that, is that position should be first secured before induction, because the characteristic of the tachycardia will be defined by that particular uh, his conduction, means how the his conduction is behaving before the tachycardia is doing, and how it is behaving after tachycardia. So if you can see the PQ, these are the conduction system, and this is the normal surface ECG. So surface ECG point of view, you can see the the sinoatrial node, AV node. So depolarization activity, this is called atrial depolarization, and atrial repolarization is somewhere here. So it is not usually visible in most of the time. And then the ventricular depolarization cells, atrial ventricular depolarization, and then atrial ventricular repolarization. It is the T waves. This is the normal conduction system, what you call electrogram, or you can say ECG, what we are getting. And but there are a lot of information which is not visible on the surface ECG, but we have to anticipate. The SA node activity start at the onset of the P wave. Then the AV node activity will be starting from the P wave to the end of the P wave. Then bundle of his, it will be coming after the P. So whenever the PR is prolonging, we can think about that it is either the AV node or his bundle diseases ongoing. By seeing the ECG, I am saying it. And when the QRS is taking time, it is the bundle of, means ventricular bundles. This is here the disease is starting, or it may be ventricular. So like that, we have to anticipate where the conduction problem is happening by seeing the ECG. If patient is having broad QRS, it is very easy. Either it is a ventricle, or it is delay is happening somewhere in the fascicles, left or right, whatever is the right bundle, left bundle. These are the only two possibilities. So what are the normal timings? So when we are doing the surface ECG, the most earliest signals will be the surface, because it is integrated activity of the atrium and ventricle. So the first will be coming the P and A. P means surface ECG. A means intracardiac. So this is it takes only 20 to 60 seconds. Means surface ECG will be preceding the intracardiac. Are you getting this point or not? Whatever surface, yes, it is the first thing. Means even you are putting the catheter inside, and most of the measurement, either you are putting the HRA or this surface, HV. The first signal what we see is the surface ECG followed by the intracardiac. There will be always some lag, and that is why PA interval is around 20 to 60. AH interval starting from A means intracardiac atrial activity to the his is around 50 to 130. It can prolong when the patient is having vagotonia. It can get shortened when the patient is having sympathetic drive. So this is one of the most variable interval in the patients of in any patient, 50 to 130. It may go to 200 also. AH interval is A to H, means the time it is taking to reach the AV node and crossing it also, because crossing will happening into the AV node. So this is basically the AV nodal delay starting from the atrium. It may be SA node to the AV node. What is the time it is taking? So it may be 150 to 130. 50 to 130. This is the his timing. From his, there is a means the signals we take two parts. One is the his proximal and distal. I have not described. So what happened? The time it is taking from this is the AV node up to this one is already been discussed, 50 to 130. But after his to the bundles, it is a totally different timing. And this timing is very vital in most of the information when we are doing the EP study, because if HV interval is first is his, how much time it is taking in his. So normally it is 10 to 25 seconds. So catheters we keep, and this is H1 and H2. There is a timing, and if this timing is going more than 30 seconds, we say there is an intracardiac block, intrahesian block. You must be. I will come across the how the blocks we are defining. Infrahesian, suprahesian, and intrahesian blocks. There are three level of blocks can happen. And then comes the HV interval from the his to the ventricles, how much it is taking time. So this time is usually fixed 35 to 45 it is mostly, and if it is crossing any time 55, we say there is a disease in the his bundles. And HV interval. So this information is very important to decide regarding the type of conduction is happening. So whenever there is a means HV interval, you can see it is 35, 55. It is getting shorter, means it is less than 35, or it is becoming negative. Means ventricle is activating before the his bundle. Are you getting this point or not? You are active. Everything should go like this one. Is it there? But and when will be it is A, H, and V. But in any situation, if this is being bypassed, it is going like A, sorry, A, V, and H. Is it possible or not? The electricity is not going faster on this line, but it is going faster on this line. So what you are seeing, the delta wave that will be start reflecting here. So all the patient of WPW syndrome, they will be having the pre-excitation. Wherever the pre-excitation, this HV interval will get shorter and even become negative also. So negative that only three condition: ventricular pre-excitation, PVC. PVC has come, then also it will be a negative or it may be shorter. And third is catheter recording the right bundle potential. So when you are keeping a catheter and taking these signals from here in place of his, it will be negative. Means it will be shorter. You are making the catheter malposition responsible for the shorter and long HV interval. So whenever it is taking time from the his to the ventricle more, means the disease is there in the conduction system, and that is infrahesian. Infra means below the node. So whenever HV interval is more, means it has already one is SA node, which is synthesizing the impulses. Second is the AV node, which is somewhat predictable. Means it is giving 70 to 90 or 100 beats. It will be giving 40 to 50. But something below is around 30 to 40. So the pacemaker, which is below the AV node, is always unpredictable. You can't rely on. That's why the broad QRS will be there. And that, so whenever the HV interval, at least in this class, you should know the importance of HV. HV interval when it is short, one condition you have to remember: WPW syndrome, pre-excitation. Many we use the second word manifest pathway. Okay, these are three words we use: manifest pathway, delta waves, or WPW syndrome, or ventricular pre-excitation. All are same. Okay. Second comes if the HV interval is prolonged. So this is the indication of pacemaker. So these two things at least you should remember. And what is prolonged HV interval? More than 55 millimeters. Whatever we are in milliseconds. Sorry. So milliseconds, if it is crossing, means the patient can be given. 75 is usually, and 100 above is always and always the patient should go for the pacemaker. And how we are measuring. So this is important. This is A. You can see H, and this is a V. So measurement of HV interval, it is a V here. H started, and V is always not the intracardiac. We are using the word intracardiac for A and V, but measurement is with the surface ECG. Okay, so a lot of time, even a few new electrophysiologists, they don't know how to measure it, because this information is very important. HV interval, though we are using the word V means intracardiac, but the measurement is always with the surface ECG. Okay, so surface ECG, wherever you are getting the QRS, the earliest part of the QRS will be taken as the onset of at the ending point of the HV interval. So AH, this wherever the vagotonia will happen, it will start prolonging. And HV interval is always and always fixed. It will never get either by the vagotonia or sympathetic drive. This time is fixed. It will be always less than 55, or you can say 35. If it is prolonging, means that there is a disease in the conduction system. This conduction system is weak. So AA interval, you give the atrial cycle length, AH in the AV conduction, HV is in the his conduction system. And this is the timing what I was discussing there. So 30 to 55 is the normal HV interval, AH is 50 to 150, and this is the ERP. ERP means at what rate you can pace the atrium. So atrium can be paced up to 150 to 360. 360 means how much heart rate you can go? 150 means up to 400. 400 heart rate, 400 beats per minute you can pace. It will means when we are pacing, it can go. And ventricle, it is somewhat lesser, 170 to 90 it is. So refractory pain means when you are giving, we will come across that also. It is not going to capture. You can pace, no? You are pacing at 60, 100, 90, sorry, 100, 110, 200, 300. So there will be rate, you are giving a rate at which it will not capture. So that rate we call as a refractory. After that, it will not capture. Whatever current you give, it will not capture. So that is called refractive. Effective refractive period. For the His Purkinje system, it is 330 to 450. So this is the basic electrogram what we keep, and this has to be measured in all the EP cases. The first measurement what we have to do it, and pre-EP study, and after that post-EP study. So when we are measuring all those things, we have to see, okay, HV interval pre and post is same, and there is no harm has happened in the conduction system while giving ablation. And these are the catheters what we are putting. So this is 4 catheter study. Okay. So one catheter is into the coronary sinus, which you are using. Which catheter? Which catheter? Decapolar. So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. 10 poles will be, this is called decapolar. This is the His catheter. 1, 2, 3, 4. Usually quadripolar it is. And this is the RV. Again, it is a quadripolar. We usually use the ablation catheter for it. And there is again one quadripolar, 1, 2, 3, 4. And this 4, why we are keeping? We want to see the pattern. If you are putting here and signals is going from up, down, down, means it is going like up to down. Anything you are putting like this one, so we are seeing the current is flowing like this one, or it is going like this one. Directionality we are able to identify. Just think about if a patient is having atrial tachycardia, which is coming from this side, lower right atrium, and one tachycardia is coming from the upside. So by seeing the catheter, this HRA, we can able to identify. If it is the activation, the first signal is coming here, the second signal is here, third, it is going like this one. Means the what you call, this HRA 1 is the late. If you are in the cath lab, you will be late, early, later. These two words will be used. So if your HRA is late, means it is a signal here. Like just think about, these are the 4 poles of the HRA catheter. Just think about it. This is the early on the timeline. This is a timeline, na? So this is the first, this is the second, this is the third. So if it is happening like this one, HRA is first, then the HRA 2, 3, 4, normal. But if it is happening opposite, this is coming here, this is coming here, this is coming here, and this is coming here, what will happen? It is down to up. So this is the way we see the signals when we are in the EP lab. It is going up to down, or it is down to. How we are going to see the electrical system? Localizing. See the electrical system, it is going up to down. So that's why these 4 poles is going to give all the informations. What is it? It is first is happening, signal is coming here. Okay, it is SA node. So SA node is giving the signal. If something is happening here first, means the signal is coming from the lower part of the atrium. Some focus is here and it is going up current. You are inducing the tachycardia. The first signal is coming here and second signal is coming here. It means short circuit is happening here. There is some pathway here. Simple. Identified? Over. We have to go the transeptal, ablate it, come out. So Like that we detect the information. So you can see this is a normal normal activation sequence. HRA, his, and this is CS. So first signal is coming at the HRA, second is coming into his, as you know it is on the lower part, and third is coming into the CS. CS means coronary sinus. Coronary sinus is the left side. But if you will see, it is almost same, just minor difference. So these signals, due to Bakeman bundle, if it is working very well, these signals will be almost similar. Means minor difference will be there. When Bakeman bundle, what I was saying, which is connecting between the right atrium and left atrium, it is diseased. You will see the timing of the HRA and the CS will be very far. It can happen. Okay. You can see this is the line we have to drop. Okay, and you can see first signal is coming the HRA, then it is his, and it is CS. You can directly see this is the pattern of atrial activity. This is atrium, A, H, and V. So this is activation in the sinus. So first measurement, AA measurement. Second measurement, it is how much it is? 110. 110 means heart rate is more than 60. If it is more than means just you are dividing by 60,000, you will get the information. This is second million AH interval. This is the AH interval, how much it is? 110. Now coming to H to V, the important information, it is around 70. So is it normal or abnormal? Huh? Prolonged. Very good. So HV interval should be under 55. It is prolonged. If the patient is giving a history of syncope, put a pacemaker. Okay. So HV interval more than 100 is usually a class 1 indication. Class 1, class 2, class 3 indications are there. So class 1 is above 100. Sometimes it is taken 75 also. There is always changes in this one. But yes, 70 millisecond is somewhat prolonged HV. And in a background of syncope, it should be taken more seriously. So this was the last time class which you may have missed. This was the revision of that. We are having around 20 minutes more maximum. So this was regarding the normal baseline. Today we are going for the Brady evaluation. Means if the patient is coming from the low heart rate, how the AP study is going to help us. So there are sinus nodal diseases which are very common when the person has grown older, and in that there are two. There are possibility the patient may be having an atrial fibrillation and he is doing good, and all of a sudden he is having syncope. How you are going to identify that patient is having atrial fibrillation as a cause of syncope or something else? So it has been seen that some patient of atrial fibrillation will be having six sinus syndrome because the sinus is lying in the atrium. And this sinus, if it is disease, it can throw atrial fibrillation also, means due to the atrial disease, and sinus node is a part of that one. Or it may be a totally a sinus nodal disease, where we are using the word sinus arrest, sinus arrhythmia, or you can say sinus exit block, and lower pulse is going to take over junction escape. So sinus nodal disease can present with atrial fibrillation. It can present with a sinus arrest. There is a pause. There is no P waves. It can present with junctional escape, means the sinus is not giving any beat and the AV node has taken over and you are getting a junction beat. Or sinus arrhythmia is not a as such, and later on the patient is having sinus rhythm. So this all manifestation come in a patient of sinus nodal disease. And what is the most important information if you have to suspect the patient is having sinus nodal disease? So we do only one test. Huh? So there is one test. If you are suspecting a sinus nodal disease, we do SNRT, sinus nodal recovery time. So we want to see how robust the SA node is functioning, and we can check in the EP lab. We are going to see, okay, this SA node is healthy or it is disease, sinus nodal disease there or not. And for that, we conduct a test by name sinus nodal recovery time. How much time it takes for recovering when we are pacing it. So we used to see how long it takes for the sinus node to recover from the being bombarded with the external stimuli, generated a beat of its own sinus escape beat. And if it is taking too long time, patient gets a pacemaker. In the test, it gives the how much or automaticity is left in the SA node, and repeated cycle should show this one. So how we are going to conduct. So you can see this is there is a pause is coming, and this is baseline. Sorry, this is the baseline S, A to A. Okay, it is coming around 117, 1007. The heart rate is around 54. This is a common scenario. You will be getting 54 heart rate, whether it is a sinus disease or it is a brain disease. All the time there is a confusion. So if we are suspecting sinus nodal recovery time, what we are going to do? We are going to pace. You can see that these the pacing signals are there. So we are going to pace at a rate of around 120, 150, and 180. These are the three cycle lengths. We are going to pace it, and we want to see when we are pacing, it is already been suppressed. It's you are understanding SA node, which is pacing at 50 right now. Now we are pacing the right atrium with a rate of around 150, 120, 150, and 180. And we want to see if after pacing, how much time it take for its own recovery, because we have suppressed it by pacing it. Okay. So when we have stopped the pacing, it is coming 189, means around 50 heart rate. Achha. So this is the, if the baseline is like, this is the baseline in 170, and when we are pacing, it is coming 1189. Next time we have paced, it is coming 1500. Next time we are doing means at rate of 180, when we are pacing, it is coming 1800. Okay, so what we are going to do, 1800 minus, first was the baseline, sorry, 117 difference, we are going to minus it, means we are going to subtract it. The time it is called for SNRT. So this is the sinus nodal recovery time, escape rate, what is coming. And when we are subtracting from the baseline, this is the after pacing it is coming. So in this, if we are going to subtract, how much it is coming? Sorry, 189 minus 117, around 50, 50 or 70, whatever you can say. So it is not a significant. But anytime this timing, if you are subtracting, if it is crossing 525, then it becomes significant. Then we can say the patient is having sinus nodal disease. So labeling, if the baseline and after pacing the distance is crossing, the difference between the baseline and the paced rhythm, anytime if it is crossing 525, then the patient is having sinus nodal disease and he needs a pacemaker. Okay. Baseline HV intervals, and this was the thing I was saying, the suprahesian block, intrahesian block, and infrahesian block. There are three type of block. So far we have discussed the bradycardia happening at the SA node. Second, the bradycardia happening at the AV node. AV node blocks can be there, that also they the bradycardia. So suprahesian block means it is above the haze. Intrahesian means the conduction is being blocked between the upper part and the lower part of the haze bundles. The time that is called intrahesian block. And infrahesian means the conduction is happening and it is below his is being blocked. Out of this, which is most dangerous? Where you are going to put a pacemaker without any thought. Yeah. So usually the infrahesian blocks are dangerous. Infrahesian, lower the block, more the chances of the, is because see, when the AV node is, when the SA node is blocked, AV node will take over. This is called the escape rhythm. Okay. So the time you are going down the conduction system, SA node, AV node, haze, bundle, and ventricle. These are the what you call the section of the conduction system. So if a sinus nodal disease is there, usually patient will not be having syncope till the AV node is functioning very good, because the it will be beating at 60 to 100, it will be at 40 to 50, and 40 to 50 is more than enough for older patient if at all. When it is going to the his and ventricle, the ventricular rates will be very low, 35, 20 to 35, or 30 to 30, 30 to 40 in between. So it is in the lower the block, more grave it is, and the chances of recovery will be less, because the escape rhythm will be coming from the ventricles, and ventricular escape rhythm is not predictable. Okay, so infrahazian block will be always taken as more dangerous, and immediately we have to put a temporary pacemaker. Intrahazian means even in the his bundle, if any block is happening, that is also not a good thing. Suprahazian block, what you commonly see is the Venki backing, type 1, second degree, type 1. And these blocks, intrahazian and infrahazian, is usually type 2 blocks, unpredictable, anytime it can block. So intra and infra, from the what you call conduction point of view, usually if it is there, then we have to put a pacemaker. Now you can see AHV. These are infrahazian or suprahazian. How to differentiate it? This question will be coming. You are able to identify? QRS, yes. Anything more? So infrahazian, suprahazian, you have to see the important thing: AHV, AHV, AH, and there is no V. So it is supra or infrahazian? Hmm? Infrahazian, correct. Up to his you have come. After that there is no. So when you get a his, means it is infrahazian. If you are not getting his, means it is suprahazian. So this is the only EGM on which you can decide it is supra and infrahazian. We are the most important thing will be in 2:1 AV block. 2:1 AV block is there. You don't know where it is. It is suprahazian and infrahazian, where you have to put a pacemaker or you have to wait and watch. It is a Venki backing happening. Venki backing happening because Venki backing you have to see the third beat to decide whether it is a 2:1 AV block is happening or not due to supra or infra. So in that situation, that AHV, A, H, and V. If there is no H, then it is a suprahazian. If you are getting two signals, just 5 minutes, it is over. Betty, Betty, you can sit, please. This is H. But when we are putting a quadripolar catheter, we can get H1 and H2. Both will be there. So in that situation, H1 come, H2 then it will be called as an intrahazian block. Intrahazian block. When the H1, this is not coming, it is a suprahazian block. If the H has come, it is an infrahazian block. So for time being, keep only one information in mind. If you are getting his, it is infrahazian. If you are not getting his followed by QRS, without QRS, it is a suprahazian. Is it clear? Infra, supra. If somebody asks, EGM you have to go. EGM if you are getting his, it is a suprahazian. Sorry, infrahazian. So you can see this is a typical atypical Venki backing, AHV, and after that A there is no V, and there is no H also. So it is a Venki backing. Now you can see 2:1 block. This is the most difficult situation where we have to know whether it is infra and suprahazian. What you are getting here? Can you identify? AHV, A. There is no H nor V. So it is a supra or infra. This is a suprahazian. Now AHV, A, no H, no V, suprahazian. AHV, AHV, A. So this 2:1 block, we are not knowing whether it is a suprahazian or infrahazian by the surface ECG. This is surface ECG. But when we are putting the catheters, and particularly the HBE catheter, his bundle, you can decide it. Okay? So like that we enter infrahazian, suprahazian. AHV, AH. What is this? Infrahazian. आप लोग भी पढ़ लीजिए 2 minutes. We are in the last part. Yeah. So AHV without H supra, with H infra. Simple. Okay? कोटि पूछेंगे फिर तुमसे. This AV block. Now you see AHV, 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 A, and followed by there is no H nor V. So what is this? Suprahazian. Good. ये हम लोग we will cover in the next. Right now, Brady is over. So Brady study is a very short study in the EP study. SNRT and EV conduction system we identify, and on that we make the thing whether it is a AV nodal disease or SA nodal disease, and like that we have to make the treatment policy. If the HV interval is normal, SNRT is negative, AV conduction system is normal, no need of pacemaker. If the HV is prolonged or the SNRT is positive or you are getting infrahazine block, you have to. But if it is a suprahazine block, again you can give atropine and leave it. Like that goes. So thank you so much. We will meet next week again.